flap elevation during the removal of the tooth crossing. So, of course, we initiated a study to address this issue. And can we take down that slide again, please? And the outcome of this study was published in 2009. It was called Ridge Alteration Following Tooth Extraction with or without flap elevation. And again, we used our own model. On the right side, we elevated no flap, but we hemisected the third premolar and removed the distal root. On the other side, we elevated full thickness flap and exposed the ridge for 15 minutes before we hemisected and extracted the distal root. We allowed healing for 6 months, after which we took our biopsies and prepared for ground sections. If possible, you can take out that line. This is now the right side with no flap elevation. And here you can see the distal root of this premolar has been removed. And there are no signs of flap elevation. And then on the left side, we exposed the ridge for 15 minutes to allow the bone tissue to be damaged. And then the distal root was removed and sutured. After 6 months of healing, we compared again in our model the tooth side with the no flap side and the flap elevation side. And we found that in the apical portion, as compared to the tooth side, there was no change. In the marginal portion, as compared to the tooth side, there was no change. But in the marginal portion, coronal portion, there was both on the no flap and on the flap side 30 to 35% reduction of the dimension of the ridge. So this means that from this type of measurements, there was no effect at all of flap elevation. But we also wanted to make sure that the flap we elevated had the anticipated effect on the roots that were remaining. Because we knew from the old studies from the 60s that flap elevation and exposure of the root cementum to the oral cavity may cause attachment loss. So we performed these stomatic measurements on the no flap side and on the flap side, in the buccal compartment and in the lingual compartment. And the first measurement included the distance from the gingival margin to the bone crest. And as you can see that these dimensions on the buccal and the lingual surfaces respectively were very similar at the flap side and on the non-flap side. Here we can see that we had no loss on the lingual surface, but we had loss of 0.018 millimeter, close to 0.1 millimeter, on the no flap side. And when we elevated the flap, the attachment loss was 3 times larger. And this, my dear colleagues, are measurements that are in full agreement with the data from the 1960s and 1970s, when we discussed so much whether we should use flap elevation in periodontal surgery or stay with the so traditional gingivectomy procedure in conjunction with pocket elimination. So the conclusion from this study is that tooth removal resulted in a marked reduction of the size of the marginal third of the ridge. But the procedure used during tooth removal, flapless or after flap elevation, did not influence post-extraction ridge alterations. Now, the next comment that was made was that, Dr. Lindhe, we can counteract these regioresorptions by placing implants in the fresh extraction sites. And these comments came mainly from Southern Europe and from the United States of America. So we said, okay, let's test this hypothesis. And we presented a study by Araujo, where we installed implants in single extraction sites in the dog. We again elevated flaps because that doesn't influence the outcome. We extracted the distal roots of the third and the fourth premolars on both sides of the midline, both on the right and the left side. And then we installed implants and allowed a semi-submerged healing. The implants that we used were ITI implants, Straumann implants. And then we took biopsies after 3 months. So this is the implant site, the right side, and here you have the two candidates for being involved. And now we have removed the distal root of the third premolar and the fourth premolar. And now on the contralateral side, the left side in other words, we had the coagulum site. And then also, of course, we had the tooth site, which is in the center of the surgical field between the two implant sites. Here we have now installed the implants, and you know the Straumann implant has a rough surface, and the marginal portion is often electropolished. And what I would like you to observe here is that the rough surface margin is placed below the buccal bone margin, below the buccal bone margin. And here you can see the implants from an occlusal view, and this is how it looks when we have suture. Semi-submerged healing is allowed, as is often the case with the Straumann system. This is the contralateral coagulum site, filled with blood, and then we suture, and now we allow 3 months of healing. What you can see here now is the buccal convexity that is illustrating the presence of a mesial root here. The same convexity illustrating the mesial root over here. You can also see that between the roots we have a concavity in mesiodistal direction. And here you can also see that we have an invagination between the two roots. This is the implant side after 3 months of healing. And when we probe around here, we can see no bleeding or probing. So we take a radiograph of this particular area, and in this radiograph we can see bone both around the tooth and around the implant. And osseointegration is as perfect as we can anticipate to be observed in the radiograph. So everything looks fine. So this is now the biopsy from the coagulum site. B stands for buccal. Newly formed bone is always a little bit darker stained than old bone. So obviously this bone we find here in the center is newly formed bone. This is the top of the lingual crest, old bone, and this is the top of the buccal crests, old bone. So this is newly formed. What is then the distance between the lingual and the buccal? Well, in this model, it's 2.2 millimeters. Then we go to the implant site, and we start with the lingual surface. And here you can see beautiful osseointegration, as is often the case with the Straumann implants. We magnify this area, and we can see darker bone, which is newly formed bone. We see this particular line, which is called a reversal line. It means that this is to the level where, following implant installation, the bone has initially been resorbed, and then new bone has formed into contact with the implant. This is straightforward biology around implants and how the healing occurs. So this, to me, tells us that this dog knows how to form bone. There's nothing wrong with the dog. His osteoblasts and osteoclasts are in good function. So this is how it looks at the buccal surface. This is the SLA surface where the bone level hypothetically should be located. On the lingual surface, this distance is 0.2 millimeter. And on the buccal surface, this distance is 2.6 millimeters, which makes a difference of 2.4 millimeters. In other words, very, very similar to what we found in the coagulum site. So if we now make the trick, so we place the edentulous site next to the implant site, and we combine the lingual walls, and we combine the buccal walls, you can see the dog couldn't care less if we placed an implant in the socket or not. Now this is how the situation looks on day 0. Buccal again is to your right. And this is the lingual surface, the buccal surface, the buccal void. We magnify this area. We have bone here, we have implant here, and what do you think on day 0 we have in here? We have a coagulum. And we know from the walls here, cells and vessels will go in and form a granulation tissue, provisional matrix or an osteoid, and then bone. You understand? At 3 months, sure enough, this is bone formation. Naturally occurring bone formation. But what about this stuff? What forms in here on day 0? Blood clot, coagulum, granulation tissue, provisional matrix, woven bone, but then the entire framework for bone formation goes away. And then, during remodeling, the bone tissue disappears. This is how it works. So now we go back to this illustration. And now comes the critical issue here. Clinically, this site looks perfect. In the radiograph obtained with the mesiodistal orientation, so we can measure the bone level at the mesial and distal surface, it looks very much okay. But as a matter of fact, following immediate implant installation, this is how it looks at the buccal surface. And therefore, my dear colleagues, to measure mesially and distally the bone level following immediate implant installation is not a sufficient measure. We only fool ourselves. Let me show you a human case. This may only happen in Brazil and Sweden, by the way. I don't argue the case that this happens in Seoul. But here you have one of my patients. This tooth, which you see in radiograph of here, could not be maintained. So I removed the tooth and we placed an implant. It's an AstraTech implant. And here you can see bone. And this is the corresponding radiograph. Now the patient comes back after 3 months, and this is what we see in this case. Never happens in Korea, I'm sure. But if biology works in Korea, then this happens every day. Okay? This is how the case looks at 3 years. Look here. You can probe. There is no probing depth, no bleeding. This is how the radiograph looks. But then said, let's take a CAT scan. Bingo. Let's take another CAT scan. Bingo. And in our radiology department, they had got a new device called three-dimensional acquitomo. Bingo. No buccal bone. How thick is the buccal bone in 80% of all cases? Well, less than 1 millimeter. Shallow probing depth, connective tissue integration. Is this a success or is it a failure? I don't know. Maybe it is a success. As long as the patient has a good keratinized mucosa, the patient cannot see the buccal surface of the gray implant, so that may be fine. Another case. We have just now removed this tooth, and the question is, does this bone belong to the tooth? Is it bundle bone? So, if it is, problem. Now we place the implant in the center of the socket. And then after 3 months, when we make our re-entry, bingo. Or whatever we call it when we see this. Another case. This is 7 months after implant placement. And this is how it looks in the radiograph. This is 5 years, and now you can see that there has been some change in the clinical picture, but not in the radiograph. You can see that we have lost bone here, because now you can see through the mucosa this gray zone. No change in the bone level. Now, the third-dimensional acquitomo illustrates that there is no buccal bone. So now we go to tooth number 1-1, which is the neighboring tooth. And we take a CAT scan. Here you have a thin buccal bone plate. Now we remove the tooth. And if we don't know what is going to happen to the buccal bone, if we, in other words, are ignorant, then we place the implant like this. But this bone is going to disappear to this level. And my dear friends, if you take a CAT scan of an edentulous front tooth region in the maxilla, this is the profile you see in the tomogram, for instance. And this is then how you place the implant. That's the point. So having seen this now, we ask the question, can we, at single immediate implant sites, mask the effect of buccal bone resorption by placing the implant in a lingual or palatal position in the socket? Well, this is again studied by Arujo and myself in dogs. We elevate the flap. We now removed the distal root of the third premolar, which is a relatively small root, and the first molar, which is a relatively big root. We use the same dimension of the implant, 4.1 millimeter in diameter, Straumann implant, allowed non-submerged healing. And then we took biopsies after 4 weeks and 12 weeks. This is at 12 weeks. Now this is following implant installation. What's the main difference? Dimension of the implant is the same here as here. The main difference between the two sides is the gap that exists around the implant placed in the molar side. And this gap is filled with blood, so it will be granulation tissue, provisional matrix, and bone during healing. Again, remember, we always place the implant so that the rough surface margin is below the buccal bone crest. After 12 weeks of healing, the soft tissue looks okay. So this is now the third premolar site, where the alveolar socket is relatively small. Buccal is illustrated to your left. This is the SLA surface border, in other words, the rough surface border, which was located below the buccal bone crest. So this is how much bone we have lost. I have now illustrated this first thread with this red cartoon. And you can see that at 4 weeks, there is bone above this cartoon. And in higher magnification, you can see the newly formed bone on the inside, osseointegration, and we also have newly formed bone on the outside because of flap elevation. When we elevate the flap, we always damage the surface of the bone, so we get slight resorption and then new bone formation. So this is osseointegration. And also on this side, on the lingual surface, bone tissue is in the process of being formed. This is how it looks at the molar site. A bigger gap, and you can see that the tissue is trying to produce a lot of bone on this side as well as on this side. The bone margin is here still coronal to this rough surface border. So this is the area where we will anticipate woven bone to form during healing. So this is now 12 weeks, and this is the premolar site. You remember this guy, the red guy, had bone on top of him at 4 weeks. Now it's lost. So it means that osseointegration can occur initially, but when the bundled bone is lost and the outer framework is lost, osseointegration disappears. So the whole concept that by placing implant in a fresh extraction socket, you can prevent the biologically dependent changes of the tooth removal. It's stupid. And it's an invention by a dentist or invention by dentists with no knowledge of biology. So this is how much we lose here. And you can see that on the lingual surface, we have reached the SLA surface. Now we go to the molar site. SLA surface. Here we have hardly any bone loss at all. But remember now that this is the newly formed bone that has formed in the defect, in the gap. The old bone was here. So all this bone has disappeared. But this bone has come back, and therefore we have been able to mask the effect of buccal bone resorption. So the conclusion is that following tooth extraction, the walls of the socket diminish in both width and height. A small distance between the implant and the outer surface of the bone will result in recession of the marginal bone-to-implant contact, while a large distance between the implant and buccal bone, for instance by placing the implant in a lingual palatal position, and hereby the establishment of a marginal gap, will allow bone-to-implant contact to remain. But we treat not dogs, we treat patients. And therefore, we started together with Dr. Botticelli a study in 18 subjects with 21 single extraction sites, canines and premolars, in both the maxilla and the mandible. That site where the teeth had been scheduled for extraction and an implant-supported restoration was planned. The implants were placed and re-examinations performed at a re-entry operation after 4 months. At the implant placement and re-entry, the dimension of the buccal and lingual walls was determined by measuring the distance from the implant surface to the outer bone walls at the buccal as well as the lingual surface. Here you have a case. We have just removed the first upper premolar. We have one buccal and we have one palatal socket. Where do we place the implant? In the buccal socket, in the center, or in the lingual socket, or the palatal socket? Well, we place the implant in the palatal socket. What will happen here? The buccal socket. Blood clot, coagulum, granulation tissue, provisional matrix, woven bone, no function, bone marrow, and the whole tissue will disappear. That we didn't know, but now we know, because this is how it looked after 3 months. But we don't have to be this intelligent. We can also use common sense, because we can say, listen, this patient obviously also had a second premolar once upon a time. And during healing following the removal of this molar, this much tissue has been lost. So the same tissue amount must be lost on the first premolar. So that means that implants must be placed palatal to a line illustrated by this dotted yellow line. It's just to use our clinical common sense to understand what to do. Here we have another site, an upper premolar at the implant installation, and this is after 4 months. The geometry is not exactly the same in the photograph, but you can see that the size of the box preparation is the same. So therefore you will also enjoy to see that this profile has been moved much closer to the buccal portion of the implant after 3 or 4 months of healing. So our results were the following. The distance from the implant surface to the outer bone wall was at baseline 3.4 and at 4 months 1.5 millimeter, which means a 56% reduction. On the lingual surface, we had a 27% reduction. And where have we seen these figures before? That the resorption at the buccal surface is twice that of the lingual surface? Well, that was studied already and published by Piotrkowski and Maslow in 1967. So again, you can see the whole idea that implant placement in a fresh extraction socket can counteract anything in terms of ridge modeling and remodeling is nonsense. Recently, we were part of a multi-center study that was published in Clinical Oral Implant Research in the January issue this year, called Alveolar Ridge Alterations Following Tooth Extraction and Immediate Implant Installation. And here you have the 4 centers that took part: Bern, Madrid, Gothenburg, and Italy. The target sites were maxillary incisors, canines, and premolars. In other words, sites in the aesthetic zone. We extracted central incisors, 10, lateral incisors, 19, and 54 premolars. And the reason for tooth extraction